If I look at shoulder, it is the most common joint damaged in swimming. And swimming is the most common joint for damage of shoulder, vice versa. Shoulder, what gets damaged? The rotator cuff area. What is rotator cuff? Made out of 4 tendons: supraspinatus, infraspinatus, teres minor, subscapularis. These 3 tendons, they go on the greater tuberosity. Subscapularis goes on the lesser tuberosity. Subscapularis is internal rotator. Rest all do abduction plus external rotation. So many a time they ask you, the tendon which is not inserted in greater tuberosity, subscapularis. So when I take my hand and take it towards the back, this is internal rotation. If I am able to lift it up, it means my internal rotator subscapularis is intact, called as lift-off test. And if I am not able to do that, it means there is damage to the subscapularis tendon, so internal rotation can't occur. Remember, when you have a rotator cuff tear, you do a repair in a young patient. But if it's an irreparable tear, do a tendon transfer. This is what is the protocol for managing the rotator cuff tears. When I look at shoulder, it is the most common joint to dislocate. Shoulder dislocation usually occurs with abduction externation force. With this force, when the dislocation occurs, the arm is abducted, and if you look at the joint level, the head is below the level. I remember it like this: down and out. Means if this is the glenoid, the head of humerus will be below the level and the arm will be abducted down and out in anterior dislocations of shoulder. Whereas in posterior dislocations, whether it's a shoulder or a hip, the head of humerus or the femur will be at the joint up and will be adducted in. So in anterior shoulder dislocations or hip dislocation, the heads of humerus and femur are down and the limb is out. Whereas in posterior, it's up and in. Remember that. So when there is abduction externation force, you are not able to touch this hand to the opposite shoulder. This is called as Dugas test. Inability to touch the tip of opposite shoulder. Dur gaya opposite shoulder means gone away. Dur means away. Gaya means gone. Opposite shoulder, Dugas test. Similarly, if you look at the circumference and of the axilla, right? So when the head comes down, the circumference of the axilla will be more. So circumference of the axilla lengthens when the head is away. Galloway test. Third, if you place a ruler, and when you place the ruler over the lateral epicondyle, it will be away from the tip of acromion because our head has a contour. But when there is a dislocation, the ruler will touch both the points, acromion and lateral epicondyle. So ruler touches lateral epicondyle and acromion. Hamilton ruler test. And the fourth test is the Brand's test, where the vertical length of the anti-axillary fold is more in anterior dislocation of shoulder. When we reduce the shoulder, the most common maneuver to reduce it is Kocher's maneuver. In Kocher's maneuver, you do opposite of abduction externation. But sometimes to open a lock, you have to go in the same direction. How do you do it? Traction. External rotation, you are unlocking, but increasing the deformity. Adduction and medial rotation. So in Kocher's maneuver, which is the most common method, traction, external rotation, adduction, and medial rotation. Remembered by the mnemonic team. Stimson's maneuver, gravity assisted reduction of any joint in human body. Hippocrates maneuver, you put your feet inside the axilla and apply traction. This is not to be done. Hippocrates' oath is taken. Maneuver should not be done because it can cause neurovascular compromise. When we come to instability, anterior instability, posterior instability, and inferior instability. There are three types of instabilities. Anterior instability, you will do abduction, external rotation force, the head of humerus will pop out. Posterior instability, adduction and rotation, it will go at the back. There's only one test, jerk test. Inferior, if somebody pulls the humerus or the arm vertically, there will be a sulcus beneath the acromion called a sulcus test. If a shoulder is inferiorly unstable, it means it's unstable everywhere, called as multidirectional instability. It means the patient has hyperlaxity. You will look for Ehlers-Danlos syndromes, Marfan syndrome, osteogenesis imperfecta, or Larsen syndrome. These are four syndromes. Ehlers-Danlos is classical. So, this force of abduction externation can cause apprehension on the face, called as apprehension sign. Can try to get the head out, anterior draw test. Can be also called as a fulcrum or a crank test. They all mean the same. Abduction externation gets the head out. Posterior, jerk test. Inferior, that's the sulcus I'm talking about. Whereas, when I talk about instability, cause-effect relationship, you know, cause is a dislocation. Effect is a damage. Damage where? Either it can be a damage to the glenoid labrum, the fibrocartilage around the glenoid, or it can be a damage in the head of humerus. So this damage is the effect which further causes a dislocation. Cause, dislocation. Effect, damage. Damage causes dislocation. So most common complication of a shoulder dislocation is a shoulder dislocation again, recurrent shoulder dislocation. Axillary nerve damage comes next to it. So, when there is a tear in the anterior part of glenoid labrum, it's called as a Bankhart's lesion. Remember, Bankhart's is a tear anterior. If you have an option of anterior tear versus anteroinferior, anterior is better, as described by Bankhart's in his article in 1938. In the head of humerus, H for Hill-Sachs, H for humeral head, it's a posterolateral defect. In the anterior, instability. Whereas, in posterior instability, you have an anteromedial defect remembered by the mnemonic RAMP, called as reverse Hill-Sachs, anteromedial defect in posterior instability. You know, anterior dislocation, the head is down and out. Posterior, it's by the side of the body at the level of the glenoid, up and in. Anterior dislocation, posterolateral defect in the head. Posterior dislocation, anteromedial defect in the head. So it's opposite. And classically, the recurrent dislocation have been classified by Matsons into two types, TUBS or embry. TUBS, traumatic, unidirectional, usually anterior. Bankhart's lesion, repair it, called as Bankhart's surgery. It has a good prognosis. Whereas embry is atraumatic, multidirectional, so hyperlaxity. Bilateral, multiple joints involved. Rehab is the treatment, rarely surgicals. Poor prognosis. So shoulder instability, there are lots of surgeries. Remember three. Bankhart's tear commonest, Bankhart's repair. Subscapularis, a very important muscle around the shoulder. Overlap and tighten it. Will act like a closed door mechanism, will not allow the head to come out. Or Bristol-Letarget procedure, where the coracoid along with attachment is fixed with the anterior part of the glenoid, will act as a check. So these are three methods which you should know. Coracoid and subscapularis they love. That's why I included a procedure related to them. Bankhart's is the commonest. When there is a shoulder dislocation and if it goes posterior, remember, posterior dislocation of shoulder, always remember that it will lead on to, most commonly, the cause, we believe epilepsy and electric shock. So posterior dislocation of shoulder, there will be epilepsy and electric shock as the cause. The glenoid head looks like an electric pulse sign. And the glenoid is empty. It's also called as empty glenoid sign. So posterior dislocation of shoulder, which is a rare variety, anterior is 95%. But in posterior dislocation, you will have 4 E's: history of epilepsy or electric shock, empty glenoid sign, and electric pulse sign. Whereas inferior dislocation, there is hyperabduction, that's how it looks like, the salam position, or luxatio erecta, because I told you inferior instability means multiple directional instability, hyperlaxity syndrome, luxatio erecta. You know, trauma will involve the nerves. Let's have a look at what nerves are involved. 4 classical: around shoulder, axillary; around humerus, radial; around the medial epicondyle, ulnar; around the head of radius, posterior introitious nerve. These are 4 classical in upper limb. In the lower limb, around the hip, sciatic nerve; around the knee, specifically neck of fibula, common peroneal nerve causing a foot drop. So shoulder, axillary; humerus, radial nerve; around the elbow, ulnar nerve; and then when you look at more, hip dislocation, sciatic; knee, common peroneal. Some other nerves that you should remember: supracondylar humerus, which occurs in children; 4 nerves in this order: anterior introitious, which is a branch of median nerve; radial, then ulnar. These are the order in which they occur. Or cubitus valgus. Valgus means distal parts away from the midline. There will be traction on the nerve behind the medial epicondyle, slow onset, also called as tardy ulnar nerve palsy. Tardy means slow. Around the wrist, you have the median nerve. And then there is something called as a montagia. Montagia is a fracture of ulna with the dislocation of radial head. And around the head of radius, you have a nerve called as posterior introitious nerve, which is known to cause finger drop. We did this when we did the chapter of nerve injuries. So this is montagia, where you will have posterior introitious nerve involvement, and then around the wrist, median nerve; around the hip, sciatic nerve; around the knee, common peroneal nerve. Remember, majority of the questions, they come on the radial nerve or common peroneal nerve, and sometimes they talk about montagia involving the posterior introitious nerve. Now this is what we discussed. Radial nerve is damaged in fracture shaft of humerus at the lower 1/3 level, called as Holstein-Lewis sign, and it occurs why? Because the radial nerve is fixed to the intermuscular septum at the lower 1/3 level. Montagia, it's a fracture of ulna with dislocation of radial head, and here the posterior introitious nerve gets damaged. Pure motor nerve. Common peroneal nerve, foot drop. This is a question that came in NEET 2019. They had shown an image of a foot drop and asked you the nerve involved, which is the site, neck of fibula. And remember, foosh, fall on an outstretched hand, very commonly asked in the exams. The most common injury that occurs overall in foosh, Colles. Colles also is the most common fracture in the elderly. If they ask you foosh in the young, scaphoid. And foosh in a child, supracondylar fracture of humerus. These are the foosh fractures that one must remember. Nowadays, they are asking you a lot of questions on foosh. Let's complete the list. We did scaphoid, we did Colles, we did supracondylar, some more. Starting from the shoulder girdle, fracture clavicle, fracture humerus, lateral condyle humerus, radius, Galeazzi, radial styloid fracture, apart from the list I have mentioned. Remember, fracture humerus and scaphoid are two fractures of upper limb where you rarely operate. But sometimes in fracture humerus you operate when it's associated with a vascular injury, which is an absolute emergency. In orthopedics, there are some rare injuries which need surgical intervention on the spot. Number one is a pelvis fracture, life-threatening. Number two is a vascular injury, limb-threatening. Number three is compartment syndrome, again a part of the limb threatened. Number four, septic arthritis, joint is under threat. These are four surgical emergencies that one should keep. So vascular injury, number one, multiple fractures for rehab of the patient, pathological fracture to establish the diagnosis and establish union, and when the radial nerve is involved after reduction. These are the indications of fracture humerus, which can be either plated or you can put a nail depending on the level and the indications. Clavicle, the most common bone to fracture. Fractures at the middle 1/3. If that's not the option, you will select the medial 2/3 and lateral 1/3. Treatment is observation, give a sling, simple support, and figure of 8 bandage. With the modern treatments coming up, this is one fracture where the surgical intervention is going up. The indications are when it's a comminuted fracture, when it's an open injury, and when it's a floating shoulder. You know what's a floating shoulder? Floating means there are two bones forming a shoulder fracture like clavicle and the humerus. So you need to stabilize, otherwise the instability will cause non-union. Clavicle unites. Only floating shoulder can cause this complication, whereas malunion is much more common in a clavicle injury. 3-point relationship around the elbow. The 3 points around the elbow, when you make a 90-degree angle, are the medial epicondyle of humerus, the lateral epicondyle of humerus, tip of olecranon. They make a triangle. When you have an extended elbow, the 3 points are in one line. In 90-degree, they form a triangle. The 3-point relationship is classically disturbed in dislocation around the elbow. And the 3-point is classically maintained when the injury occurs above or below the level, like supracondylar humerus fractures. These are the questions which are very commonly asked. Coronal plane deformity. This is coronal plane, this is sagittal. Coronal plane deformity. When your limb distal to a joint goes towards the midline, it's varus. And when the limb goes lateral, it's valgus. Valgus, there is a L. So it goes lateral. Look at this. The angle between the arm and the forearm is called as a carrying angle. Carrying angle is more in females than the males. The range of carrying angle goes from 3 degrees to 11 degrees. When the carrying angle decreases, it's called as cubitus varus, towards the midline, seen in supracondylar fracture humerus. When the carrying angle increases, that is the distal part goes laterally, it's called as cubitus valgus, seen in lateral condyle humerus. The difference is, this is non-union of lateral condyle humerus and supracondylar humerus is malunion. So that's how you should remember. Supracondylar fracture humerus, a very common fracture around elbow, one of the commonest injury in young children. This fracture, when occurs with milder force, can have a fracture which is not displaced, not very evident on the x-rays, but because there will be hematoma around the fracture, it will lift up the fatty tissue, the fat pad. As we know that soft tissue planes can also be picked up on the x-ray, this is called as the fat pad sign. Undisplaced, unidentified fractures of supracondylar humerus on an x-ray. But when it displaces, the most common displacement is posteromedial. It's also called as extension type of fracture. 98% of cases are extension type. The supracondylar fracture humerus, if it's undisplaced, is treated with simple slab, and if it is displaced, you reduce it and fix it with K-wires, and the reduction is close reduction. Sometimes it can damage the brachial artery. At that time, there will be pulselessness, and the management of this fracture is close reduction and look for reappearance of the pulse. Classically, in older times, supracondylar fracture humerus were treated by tractions, the Smith and the Dunlop traction. Smith traction is for supracondylar humerus fracture. It is not for Smith fracture, remember that. And fracture supracondylar humerus, the most common complication is malunion, causing onto cubitus varus or gun stalk deformity, because the limb looks like the stalk of the gum. The same cubitus varus and the gun stalk deformity are the synonymous words. When you want to treat any varus, remember, in any varus, you take out a wedge of a bone, more on the lateral side, less on the medial side, because the lateral border is bigger and the medial border is shorter. This is called as close wedge osteotomy, lateral close wedge osteotomy. Usually varus deformities are more common, and this is the osteotomy that's carried out. You will read about this when we talk about osteoarthritis of the knee joint. You have an angle called as Bowman's angle, which can tell you about the cubitus varus and its correction. Fracture lateral condyle humerus. It's intra-articular. Damages the joint. Treatment, open reduction plus stainless steel wires called as a K-wire. Fixation. Their complication is non-union, causing cubitus valgus. So distal part goes laterally, cubitus valgus. And behind the medial epicondylar of humerus, there is ulnar nerve. As the valgus occurs, slow onset ulnar nerve palsy occurs called as tardy ulnar nerve palsy. Monteggia. Monteggia fracture, it's a fracture of ulna with the dislocation of radial head. It is classified by Beddoes classification. Monteggia type 1 is when the radial head goes anteriorly. Anteriorly is the most common type, the one shown here. That was the image that came. They asked you, what is this? Monteggia type 1. Monteggia type 2, the radial head goes posteriorly. Monteggia type 3, radial head goes laterally. So it's a fracture of ulna, but classification is according to radial head dislocation. Monteggia type 4 is fracture of both radius and ulna with dislocation of the radial head. It is in children usually treated by close reduction and slab. In adults, it's usually treated by surgery, and there's a procedure called as Bell-Tosse procedure, which is for Monteggia. Monteggia is very common in entrance, but what is common overall and in entrance is Galeazzi. G for Galeazzi, G for ground. So it's a fracture of the radius towards the ground, lower end, with dislocation of the distal radioulnar joint. Plus, there is a damage to the interosseous membrane. Plus, there is damage to the triangular fibrocartilage complex at the wrist. 4 components: fracture of the lower part of radius, dislocation of the distal radioulnar joint, damage to the triangular fibrocartilage complex at the wrist joint called as TFCC, and the 4th one, interosseous membrane. Galeazzi is more common and more commonly asked than Monteggia. Then come the fractures around the lower end of radius. We will first do the extra-articular fractures. In extra-articular fractures, we have the Colles fracture, the most common fracture in elderly. In Colles fracture, if I remember from the anatomy that I did, when there is a fracture of the distal part of radius, if it goes towards the first metacarpal, it's an anterior displacement, because the first metacarpal on the lateral view is anterior. And when it goes opposite, it's a posterior displacement. In Colles, the distal fragment goes posteriorly. So there is a posterior displacement. Remembered by the mnemonic PC, Priyanka Chopra, posterior is Colles. The mnemonic is slip because it occurs due to Fuchs injury, fall on outstretched hand, or a slip in a washroom. So the distal part is supinated. There is a lateral displacement. The two bony fragments are impacted, and most importantly, I told you, posterior displacement, slip. And when you reduce it, you apply opposite force. You opposite to supination is pronation. Opposite to posterior displacement is palmar angulation, and opposite to lateral displacement is ulnar evasion, called as propaganda. Opposite of Colles is Smith. It's called as reverse Colles. The displacement goes anterior. So the displacement is remembered by the mnemonic propaganda. So the cast of Colles is the displacement of Smith, and the cast of Smith opposite to it, supination, lateral displacement, impaction, posterior displacement, is the displacement in Colles because they are opposite to each other. Remember, in Colles fracture, when you apply a splint, you reduce it, you immobilize a joint above and a joint below in a splint. But in Colles, you apply a cast which is below elbow. It is exception to the rule of splintage. Below elbow cast. And this cast is in the shape of handshaking, called as handshaking cast. Whereas in Smith, the cast is opposite to a displacement of propaganda, the slip variation, but it's above elbow. It will follow the rule of splintage, immobilizing joint above and a joint below. These are intra-articular fractures. Colles fracture and its complications are very commonly asked in exam. One of the common complications of Colles is malunion into dinner fork deformity. So it looks like a dinner fork, malunion. Whereas in Smith, the malunion is opposite, causing the garden spade deformity. So Colles and Smith, they are opposite to each other. When you look at a classical history of a child between 1 to 4 years with a traction on the elbow by father, you must think about pulled elbow. In pulled elbow, a father or a mother will apply traction on the elbow. It's also called as the nursemaid's elbow. The radial head comes out of the annular ligament and the forearm appears pronated because the radial head is responsible for pronation supination movement. So since the radial head has come out, it stays pronated. The X-ray is almost normal, but the treatment is forceful supination. The moment you do that and then you flex it, you'll hear a click of the head of radius coming inside the annular ligament. Picks to point. Number 1, traction on the elbow. Age group 1 to 4. Forearm pronation.